Same. We shall now go on to our next speaker, who's going to be talking on managing hyperopia, the challenges, and learning for greater precision. And we have none other than Sri Ganesh, who is the chairman and the medical director of Nethradama Group of Hospitals from Bangalore, and again, a fantastic cataract and refractive surgeon, and with innumerable number of innovative products on his name. And on to you, Dr. Sri Ganesh.
Thank you, Dr. Chitra, and thank you for inviting me to this interesting course. Good afternoon, dear friends. So we look at managing hyperopia. I'm not going to go through the list of challenges. Of course, if you look at surface ablation for hyperopia, younger patients, high hyperopia, it is a no-no because you have severe regression because of the epithelial changes. For LASIK, you have hyperopia has its sets of challenges, regression being one because you're going to remove tissue from the periphery and steepen the center, and the epithelium tends to it's going to hypertrophy in the periphery. There's going to be an epithelial hyperplasia, and then you're going to get regression. Also the stroma, because of that you can have stromal regression. There are several studies using cross-linking in younger patients, and this shows better stability. The other challenging is the large angle kappa, which can be there in hyperop. So if you don't compensate for that, you will get an induced coma and loss of best corrected vision. What I'm going to do in my talk is go through what is new for hyperopia treatment and what is coming for hyperopia treatment. And we had an experience of doing SMILE for hyperopia. We were one of the centers in the global study. So I'll go through SMILE for hyperopia, and then later on tissue addition, the work which I have been doing. The relax SMILE is for hyperopia is virtually the same as to correct myopia. The only difference is in the geometry of the refractive lenticule, which is designed to steepen rather than flatten the cornea. So the highest area of subtraction is located in the mid-periphery and periphery, whereas in myopia it's in the center. So this requires a transition zone between the actual refractive cut and the lenticule edge to create a gradually thinning lenticule rim rather than a steep edge, so that you have, that's why you have a very large zone and you have to use a medium cone. The first study was done by Walter Secondo on hyperopic flex, and they found that there was severe regression because they used a smaller zone. The second study, again they used a 2 mm transition zone, so it was a larger transition zone, so they achieved a larger optical zone and they found that the stability was better. The Nepal trial for hyperopic SMILE was conducted by Dan Reinstein and Kishore Pradhan, and they had 4 phases: blind eyes, densely amblyopic eyes, mildly amblyopic eyes, and sighted eyes. And this was the first hyperopia in Nepal. This is the geometry of the lenticule. You can have a 6.3 or 6.7 mm optical zone, a 2 mm transition zone, a very large transition zone, a 90-degree lenticule cut, and an 8.8 mm cap diameter. So it's a very large cap diameter. You have to use a medium cone, and it's got a very small clearance from the edge, which is a 0.25 mm, and normally a 120 cap thickness. The central thickness, the minimal thickness, is kept at 30 microns, and you can remove the lenticule through a 2 mm incision. So these were the 3 phases. I will not go through it, but what they found was centration. When they compared this with hyperopic LASIK, and they found that the offset magnitude was less for SMILE than LASIK. That means the centration was better for SMILE, centration on the visual axis, than with LASIK. They also looked at optical diameter, and they found, and the amount of change in the topography, and they found that you get the same amount of steepening in the center, the zone, with a 6.3 mm SMILE as compared to a 7 mm LASIK procedure. So with LASIK you have to use a much larger zone to get the same effect. And they looked at spherical abrasion of SMILE versus hyperopic LASIK, and spherical abrasion induced with SMILE at the 6.3 to 6.7 mm zone was similar to a 7 mm zone for LASIK. And these are the details about the eyes. You can look at the outcomes. Again, this is the efficacy, and they found that the efficacy was kind of similar for LASIK and SMILE. This is a comparison between LASIK and SMILE, and you can see that corrected distance vision about better than the uncorrected, better than uncorrected, 67% in SMILE and 50% in LASIK. And safety also was very similar to hyperopic LASIK. And the accuracy, again, if you look at the accuracy and the points, the scatter diagram, it is very similar to hyperopic LASIK. This is the accuracy, 59% within half diopter correction, and 53% in LASIK. So kind of similar, slightly better in the SMILE group. But what is important is the stability. If you look at the stability is slightly better with SMILE than with hyperopic LASIK. So it basically induces less aberrations. The aberrations are less. You get an effective larger optical zone, and the stability is better when compared to hyperopic LASIK. The results are kind of, visual results are similar. And these were the 8 centers where the multicentric trials were done, 374 eyes. The results are being published. I will not go through the criteria, but I'll show you a video of how the hyperopic SMILE pattern is. So you can see that you have the transition zone, then it cuts the central optical zone, and then the side cut, and followed by the cap cut and the axis incision. So it creates a donut pattern where it removes more tissue in the periphery than the center. The center is 25 to 30 microns thick. So the mid periphery is thicker, and the dissection technique is the same as for myopic SMILE. The only difference is because this is a very large optical zone, you can't use the same dissector. You need a longer dissector. The Reinstein dissector, there were 9 millimeter dissector instead of the 8 millimeter dissector for SMILE, hyperopic SMILE. And you can see this is the topography changes. One of our patients, you can see that it's very well centered, and you can see the steepening in the cornea post-op. And if you look at the abrasions, there are hardly any changes. So the profile is very nice. This is the ASOCT, and if you look at the epithelial profile, you get this epithelial donut where you have, which is thinner in the center and thicker in the periphery. This is typical of hyperopic treatments. So hyperopic SMILE is surgically similar to myopic SMILE, and it has some potential advantages: elimination of fluence projection errors, truncation errors. Centration is similar, slightly better than LASIK. Achieved optical zone was larger, and spherical aberration induced is less. I mean, with a 6.3 mm SMILE, it's similar to a 7 millimeter LASIK, and the refractive and visual outcomes are similar to SMILE. The other topic I wanted to touch on is tissue addition for hyperopia, and we have done quite a bit of work on this. A recent publication on long-term outcomes have also been published. I'll just show you one case. This is 32-year-old male, and you can see he has +7, which is a very high hyperop, and these are challenging cases. You cannot do LASIK, you cannot do SMILE. Best corrected vision improving to 6/12. And this is the pre-op topography, both eyes, right and left. You can see that so normal topography. We used donor lenticules. These are the details of the. We used a 9 diopter SMILE lenticule, and this is the. I'll just show you. We make a pocket. We program a LASIK with a large hinge. So in effect, you get a pocket, and then you can open up the pocket and insert the lenticule. That's the opening up of the pocket. And then you put in the SMILE lenticule. Those are some of the instruments which I have devised: a lenticule holder and a T inserter. I'll just show you the video and the post-op topos and conclude. That's the T inserter, which is sandblasted, and you can use this and then just push this lenticule in. The advantage is that it is a reversible procedure. You can center the lenticule to the Purkinje image, which is on the basically the visual axis, and then close it. So this is the post-op. You can see that the uncorrected vision is 624. There was a little bit of residual sphere, 1.5 diopters. And for this we have a technique called BMR, which is again published, Bowman's membrane relaxation. And this is the paper on that. We use a Barron Striffine and just Striffine the Bowmans, so that this provides further steepening of the cornea and an enhancement. So that's the Barron Striffine. 3 turns on the Barron Striffine, you go down about 150 microns. We keep a cap of 160. You can also do PRK or thin flap LASIK for an enhancement. But that's this is what happened, that then the uncorrected vision improved to 612, which is the same as the best corrected. The residual sphere from 1.5 came down to 0.25 and plano. And this is the topography pre-enhancement. Here you can see that post-enhancement, and this is the difference. So you have steepening of more than 1 diopter with this technique. The other eye, and these are some of the pictures. You can see that the Philly with the BMR, and this is the AIOC2022. So this is the 2-step procedure using Philly and BMR, which is quite effective to treat very high hyperopia, +6 and above. We have treated up till 9.5 diopters very effectively. And this is some of the new work which I'm doing. Thank you very much for your attention.
Very impressive, Dr. Sri Ganesh, to see all your shares. Could you go to the... I'll just take one question because we're running short of time. We have 2 more speakers. In non-ophthalmic eye, what would be for a hyperopic correction, till when you would do a piggyback IOL and when you would not?
Piggyback IOL, okay. See, you can have different approaches. You can have a customized IOL where you can manufacture the IOL. You can do piggyback IOLs. You can also use a phakic IOL after implanting a regular IOL. Non-ophthalmos has its special problems. They have thick sclera, they have choroidal effusion, so you have to take a lot of precautions. We put them on atropine, give mannitol, do a sclerostomy, iridectomy, and also a hyalodectomy, and then manage it. I have a video on YouTube, but then you can use even 50 diopter lens in these patients and successfully treated. But it's more of the precautions you take pre-op and intra-op which will determine the outcomes.